Suddenly a CME on Monday. Usually we get it done usually on the weekend, Saturday, or maybe sometimes you pull it till Friday, it's still okay. Now Thursday is also physical I'm talking about. Now when suddenly on Monday is little unusual. But yes, when Dr. Naveen Jaikumar is in the city, so any day is good for neuro ophthalmology. And this is neuro ophthalmology, which is a stream which every day, even if you learn or read every day, still there is a lot of confusion. So let us, solve few of our confusion with Dr. Naveen Jaikumar, who does not need any introduction. I would like to request Dr. Amitav Biswas to chair the session, and as well as he has kindly agreed for moderating the session as well. Amitav, please come on the dais. I will request our co-chairperson, Dr. Mrinal Kanti Ghosh. Mrinalda? Okay. Mrinalda to be on chair, and Dr. Naveen Jaikumar sir to be on chair, and then we'll start the program. Amitabh, you can.
Okay. Thank you, Rupak. Yes, as you said, when Naveen is in the city, it's a good time to learn and brush up on neuro ophthalmology, a subject which seems very easy when Naveen is around, and we need to refresh our memories over and over again. I was actually gave him the idea today to start off asking a few questions based on the last talk, whether how many people can remember that. Anyway, jokes apart. So today's evening on neuro ophthalmology, where is Dr. Minalda? He is coming. Okay, he's coming. Right. So a quick introduction of our panelists. Dr. Sudipta Sahana, is she here? Not yet? Hi. From Shankar Nethralaya, Kolkata. Dr. Alokesh Ganguly from Priyambada Bella Eye Center. Dr. Shubhrangshu Sengupta, is he around? Not yet come. He is from Center for Sight. And Dr. Tanmoy Biswas from Netralayam. Is he around? Okay. Good. We have a few case presentations and short presentations. Of course, we know that we are here mainly to kind of take in whatever Dr. Naveen Jaikumar has to give us or share with us. Our first, before I go to the first talk, I must also take this opportunity to give a short introduction about Dr. Naveen Jaikumar. He is a known face, known name, yet I must tell you that he is from Calcutta, from La Martiniere School for Boys, his schooling. We were together at SN Kolkata, and that is where we became friends, and it has been more than 3 decades that we have stayed as good friends. He has also been a visiting scholar in the Chinese University of Hong Kong. He is a member of the editorial board of Journal of Neuro Ophthalmology of USA, and he is only one of the 3 editorial board persons from Asia. He is the current president of the Indian Society of Neuro Ophthalmology since 2000 last year. And he has 3 main interests in life, apart from his family and personal life. That's neuro-ophthalmology, quizzing, and of course, is there a piano around? No? Oh, that's what is missing. Well, that's Naveen for you. Welcome, Naveen. Welcome on behalf of Ophthalmic Society of West Bengal. And also thanks to Dr. Debashis Das, Dr. Rupak, and the president of OSWB, Dr. Ratish, to have organized this meeting at such a short notice. Thanks also to our sponsors for the evening, the supporter, CIPLA, who has also acted at short notice. And with these few words, we'll go ahead with the presentations. And the first presentation is is on uh, is by Dr. Debaduti Chatterjee on craniopharyngioma. Dr. Debaduti Chatterjee, uh, hello, is a third-year postgraduate at Regional Institute of Ophthalmology. Over to you.
A very good evening to all present here, to the esteemed faculty and the panelists. The case I shall be presenting is a case of homonymous hemianopia. So a 50-year-old male came to our OPD complaining of headache for the past 6 months and was not being able to see anybody on his right side for the past 1 month. The headache was insidious in onset, was dull, progressive in nature, not associated with any aura or nausea, vomiting. It was occurring once or twice a week in a month. Past history, no history of any head or ocular trauma, any past loss of consciousness or seizures, no significant family history of migraine, drug history, or any systemic illness. The patient was seen outside by an alternate medicine practitioner and was put on eye drop timolol twice daily. The general examination was alert. The patient was alert, conscious, cooperative, oriented to time, place, and person. There was no pallor, icterus, cyanosis, or clubbing or edema present. Pulse, BP were within normal limit. Respiratory rate was within normal limit. The patient had bilateral facial symmetry with erect head posture. Systemic examination was within normal limit. The ocular examination, the visual acuity without glasses in his right eye was 6/18, in his left eye was 6/9. Color vision was all right in both of his eyes. The ocular agnesa was within normal limit. Extraocular movements was free and full in all directions. Conjunctiva was within normal limit. Further examination, the cornea, anterior chamber, iris, and pupil were within normal limit. There was no RAPD. The lens showed cataractus of mild nature. The fundus showed in his right eye a mild temporal pallor with a vertical disc ratio of 0.7. The neuroretinal rim was healthy. The macula was healthy, and the peripheral was within normal limit. In his left eye, the disc was showed a VCDR of 0.6. NRR was healthy. Macula was healthy, and the periphery was within normal limit. Intraocular pressures show the right eye of 14 millimeters of mercury and left eye 12 millimeters of mercury. The CCT was in his right eye was 494 and left eye was 498. So the corrected tonometry was around 18 and left eye in his 18 and 16 in his right eye and left eye respectively. Indirect gonoscopy findings showed an open angle in both his eyes. The perimetry showed right-sided homonymous hemianopia, suggesting a lesion of his left-sided optic tract. It could be an infarct, an aneurysm, or a space-occupying lesion. Based on the history, the clinical examination, disc evaluation, which showed a temporal pallor in his right eye, and a normal neuroretinal rim, and HF findings which showed a right-sided homonymous hemianopia. Non-glaucomatous optic neuropathy was suspected, and an MRI was done. The MRI showed a lesion in his supracellular region, which was hyperintense in both T1 and T2 weighted images. Provisional diagnosis of a craniopharyngioma was made after neurology
Dr.
opinion was
Devduti.
taken.
Dr. Devduti,
Yes,
sorry to interrupt you.
Yes.
Like, if we can just stop at this point of time,
Yes, sir.
and request Dr. Naveen Jayakumar to just give us an analysis of the case. So if this is presentation, so how to proceed about next?
Yeah, I think a couple of the things that one would talk about at this time is about that whole issue of glaucoma and the general axiom that pallor greater than cupping is a non-glaucomatous neuropathy, and cupping greater than pallor is usually a glaucomatous condition. I think the first thing when I saw the vision 618 in the right eye, I was wondering whether there was going to be an RAPD in that eye. And do you think there's some explanation for that? Because the color is normal and
Sir, it could be that maybe the right eye, I don't know, the compression was not enough to induce an RAPD.
So that's one of the things we need to keep in mind. Is there an RAPD or not? So if you have, and it's always a good idea to keep RAPD and visual acuity together and see how they match up against each other. For example, if you have a slight drop in the vision and a gross RAPD, it's usually an optic nerve condition. If you have a profound vision loss and only a mild RAPD in that eye, it could be macular disease, it could be sudden vitreous hemorrhage and all sorts of things. So it's always good to match the two. Keep an eye on the visual acuity and the RAPD, see if they go matching, and then decide whether you're dealing with an optic nerve problem or not. What is interesting is, of course, that the field is a complete homonymous hemianopia.
Yes,
and as I will explain in my talk, when you have a complete homonymous hemianopia, all that you can say is that the lesion is on the opposite side beyond the chiasm. You can't get more specific than that. It's only when you have incomplete homonymous hemianopias that you can say this is a tract, this is an LGB, this is radiations and cortex and stuff like that. So that is interesting. Now, of course, we are faced with a surprise here, which is a suprasellar lesion, a chiasmal looking lesion here. So we'll continue to listen to what he has to say. And think. One thing about the MRI is very few things are bright on T1 images. Sometimes it's blood, but this kind of very white thing is usually due to fat. And craniopharyngiomas contain cholesterol crystals, which is why it's looking very, very bright on a T1. Usually, if you see a normal pituitary adenoma, it'll look gray and on T1 and little brighter maybe on T2. But this kind of very bright thing is usually fat. That way. So that's tallies with the craniopharyngioma. Go ahead, please.
Yes, sir. So provisional diagnosis of a craniopharyngioma was made after neurology opinion was taken. The patient was taken off anti-glaucoma medication and was referred to neurosurgery for further opinion regarding surgical management and is awaiting surgical management at the department. So the take-home message that I would say is that before starting anti-glaucoma medications or diagnosing a glaucoma, we should do a proper history and clinical examination and disc evaluation and field.
In fact, I couldn't figure out, maybe there are glaucoma people here. Was there anything to suggest glaucoma in this case at all?
In my opinion, no. And we'll take an opinion from one of the panelists, Dr. Alokesh.
Yes, I would definitely agree with Amitabh. There was, at least on available evidences, whatever we could see of the disc from your fundus picture, there was nothing which would suggest glaucoma. There's nothing actually.
I have a very simple and basic question for you, not a question, a request. Like for many of us, including me, can you revise and tell us again what is T1 and what is T2 in an MRI image?
That's a long story, so I'm not going to get into it, but it's important if you can figure out which is a T1 image and which is a T2 image. And the simplest way to do that is look at the water. So if you're looking at an orbit, look at the vitreous. If you're looking at the brain, look at the CSF. CSF will be, on water, will look dark in T1 images. And it will look bright in T2 images. And that's the simplest. I won't go anything more than that, but you can figure out that. T1 images generally are used for anatomy. If you want to look at structures, etc., T1 is the image to look at. T2 images highlight pathologies. So if you see something bright on T2, that there is some edema there, some fluid entering there, etc., which is why it's looking bright on T2. So just remember that on an image, if you see a dark vitreous or a dark CSF, that's a T1 image. Bright vitreous or bright CSF, that's a T2 image. T1 is used for looking at structures, anatomies. T2 is looking for pathology.
I'll just be repeating what Sir has taught us often. So if you just go to the slide where you have shown the fields. So in Neuro Ophthalmology, when we place the fields, it's like on the right hand side we are supposed to place the right eye field, and on the left hand side it's opposite the normal convention. What you have done is you have put the right hand fields there, but actually Neuro Ophthalmology, when we are to interpret, the right eye field on the right side and left eye field on the left side.
Correct. I just have one last small query to you. How do you explain this vision of 6 by 18 in this case?
The only way to explain it, I think, is that there is more of an optic nerve involvement
Sir,
on that
if
side.
I can say something, sir, the vision is actually not corrected, is not the best corrected visual acuity.
Okay.
It was without glasses, so with correction, maybe it would have improved. We did not do the corrected vision actually. No, sir, without.
The
Oh, I'm sorry. I mean, this was not. This was with the patient wearing it, and we did not correct it at the.
Yeah. Or else I would have thought
yes.
doing an OCT of the macula would have been helpful to find out some other cause.
Yeah. The other thing is, as far as chiasmal lesions producing this kind of defects, it all depends on which way a tumor or an SOL is pressing. And that is why some tumors go forward, some go backward, some pituitary adenomas love going sideways as well. Okay, so it all depends on that. It also depends upon the chiasm. As you know, some chiasms can be prefixed. If you have shorter optic nerves, the chiasm is moved anteriorly. So the pituitary is more under the optic tracts, and that's when you can get this kind of a lesion. In patients with long optic nerves, the chiasm moves backward a bit, so a pituitary tumor press on optic nerves and produce more of an optic neuropathy pictures. So just remember prefixed and postfixed chiasms also.
So shall we move on to the next presentation then? Yeah, thank you. Thank you, Dr. Devaduti. That was a good presentation. We go to a presentation by Dr. Shreyashi Ghosh, who is a senior resident at RIO, on NAION presenting as pseudo-Foster Kennedy syndrome.
Good evening, everyone. Today I have a very interesting case which came to our OPD. A 52-year-old female presented with sudden dimness, painless dimness of vision in the right eye for 1 week, which was not associated with any ocular or facial pain. There was no history of trauma or ocular surgery in the right eye, neither any history of headache, vomiting, or diplopia. However, she gave a similar episode in the left eye 6 months ago. There was no history of fever or vaccination, no history of any neurological symptoms or muscle stiffness. She is a known diabetic and hypertensive for the past 8 years and is under medication. However, she is a non-alcoholic, non-smoker, not under any ocular medication, neither did she give any family history of any ocular illness. Then we measured her BP in the sitting and supine posture, which was normal, as you can see. Pulse was 82, weight was 63 per kg. 63 kg. There was no pallor icterus or clubbing or any other abnormalities noted. In the ocular examination, her right eye vision was 6 by 36 uncorrected, which was 6 by 24 with best correction, and left eye was 6 by 60, which improved to 6 by 36. Extraocular movements were normal, free and full, not associated with any pain. Lid, cornea, conjunctiva were normal. Pupil, however, we see afferent pupillary defect in both the eyes. Color vision, we used the Ishihara chart and it revealed red-green color deficiency. Anterior chamber was normal, lens was mildly cataractous. The fundus and disc, as you can see, shows disc edema with hemorrhage in the right eye, and the left eye we see an optic atrophy, a grayish disc, narrowing of vessels with peripapillary sheathing. IOP was 14 and 16 respectively in both the eyes. So based on our history and examination, the differentials we arrived were it could be a demyelinating optic neuropathy, it could be an anterior ischemic one, it could be an inflammatory one, or it could be an infiltrative optic neuropathy. So we proceeded towards the investigations. Her FBS and PPBS were slightly deranged. HbA1c was 7.2. However, her complete blood count, ESR, lipid profile, CRP, everything was within normal limit. Chest X-ray was done where again no abnormality was detected. The autoantibodies were also negative, and RA factor was also within normal limit. Then we did a perimetry, and this was the picture that we saw. In the right eye, we see an inferior altitudinal defect with certain nerve fiber bundle defects also in the superior quadrant, and in the left eye, we see a more advanced visual field defect. And we did an OCT in which, it's not very clear, I'm sorry, the right eye showed mild retinal edema, and the disc edema was also noted in the right eye. The left eye, we see thinning, peripapillary thinning. Then we did an MRI brain and orbit, in which we did not see any signal in the stir image. We did not see any increased inflammation of the nerve, and in the flare image, we did not get any periventricular demyelinating plaques. So we referred the patient to neuromedicine for further investigations. They ordered for an anti-aquaporin 4 antibody testing, which was found to be negative. And we also did a fluorescent angiography to see the right and left eye, where we noted a disc filling delay. So based on this, we came to the diagnosis that this was a case of non-arteritic ischemic optic neuropathy in the right eye, presenting as pseudo-Foster-Kennedy syndrome. Coming to the management, as we know that there is controversy regarding the use of steroids in an NAION case, but based on the article and studies of Dr. Soham Singh Hare, where he had made a study where he found that the treated eyes performed better after giving steroids. So we started the patient on 80 milligram prednisolone for 2 weeks, and then she was tapered. Her glycemic control was advised. She was advised to not take any antihypertensives at night, and she is under observation and follow up with us every monthly. Thank you.
Thank you. Thank you. Dr. Naveen.
Just quickly, what was the vision in the right eye and in the left eye?
At presentation, sir, right eye was 636 and left eye was 660 uncorrected.
Okay. Yeah, I think the outset, I think the age, the history of microvasculopathies like diabetes, hypertension, the painless sudden drop in the vision, all do point to anterior ischemic optic neuropathy as the cause. But you are right. I think nowadays NMO is becoming more and more increasingly recognized as a possibility. So I think doing an NMO antibody is worth it in these cases, because demyelinating disease, I don't think it would fit into this age group and this kind of a thing. Infiltrative optic neuropathies, always be careful. They are always there at the back of the mind. Only thing is, if you look at the optic disc in infiltrative optic neuropathies, many of them you can virtually cannot even see the disc. There's so much of disorganization at the disc. It will just be looking like a mass of hemorrhage and exudates over the disc area. You can barely look at the disc itself. Plus, of course, you would have seen definitely changes on the MRI along the optic nerve, yes, if it was an infiltrative. Doing an MRI, I think, is important, even though it is thing. As far as steroids are concerned with 636 and 660 vision, I think we all know Here's papers there, but I think the final outcome of that is you manage each case on an individual basis depending on what you think, and you can offer the patient the option and they can decide as well, because there's no answer this way or that way to this.
Sir, I would like to ask you a question.
Yes.
Do you give steroids to all the NAIN patients, or what do you do with the NAIN patients?
No, I don't give steroids to everyone. If someone has got, mine is just a rough and ready guide. If someone has, for example, very profound visual loss, like 2 meters, 3 meters vision, etc., I would consider giving steroids. But if someone has got 660 and better, I would just observe it, because I don't think there's much of a role in that as well.
It's because, sir, in the IONDT trial, what they found out, because steroids are not of much help. So, I mean, we are always kind of whether to give or not to give.
Yes, for a long time, I think the IONDT trial did say that steroids are of no use at all, until Dr. Here's paper came out. But even with the IONDT trial, if you look at Indian neuro ophthalmologists, a lot of them were treating with steroids, depending on the visual acuity. And I think Dr. Here's paper seems to suggest that there were some amount of holes in the paper.
Yes.
But I think the take-home message after all that is you manage each case on a case-by-case basis. And I think it's reasonable to assume that if someone has got a moderate visual loss in an NAION, it is fine to just observe it. But with profound visual loss, there's no harm in treating the patient with steroids. I think that would be, as far as I'm concerned, somewhat reasonable to do.
So if the patient has diabetes, because these patients often have poorly controlled diabetes, hypertension, would you still go ahead and give steroids?
Again, depending on the vision, and if I need to give steroids, I would always coordinate it with the diabetologist.
Okay.
Always.
Thank you, sir.
Would it be
Sir,
methylprednisolone?
which form of steroid? Tablet prednisolone or IV methylprednisolone?
Well, if it's a very profound loss, like for example, counting fingers, etc., methylprednisolone would be a good idea. Otherwise, if it's like some 660 to 560 or something like that, oral pred is fine. Just remember that because you're dealing with NaION, it does not follow all the rules and restrictions of the ONTT trial.
Alokesh, anything you want to add?
Sir, what would be in those cases where you want to start a steroid, would the duration of the visual loss play any role in your decision-making process?
Certainly. I mean, if we are looking at this kind of picture where you still have a very acutely infarcted disc, then you're still open to steroids. But if the patient came after some 3-4 weeks later, then you wouldn't think of it also, because by then the edema would have reduced and gone into pallor. But on the other hand, if you saw this kind of a disc after 1 month of onset, then you better change your diagnosis. It's something else happening.
Excuse me, I feel there is a missing link in this case because that is a maximum etiology, means cause of recurrent NaION is diabetic, another one is sleep apnea. So I don't feel that is HbA1c 7.2 something that is sufficient to support bilateral NaION type disc case, sequential cases. So even in female patient also, I feel if there is a case of NaION plus minus, should have a ENT evaluation. One thing is very important because even in female patient also, snoring is a major history and risk factor. If we don't do this patient can have a CVA also.
I would agree with you that yes, sleep apnea is an under-recognized cause of NaIONs, as is, for example, taking antihypertensives last thing in the night, because nocturnal hypotension does play a role in these. These are all these kinds of conditions. But having said that, NaION can be a mix of things. You can have a patient who's diabetic and hypertensive and sleep apnea. We do not know how these things interact with each other. But yes, I would agree with you that if someone has this, I think it's good for them to get treated. Not only for this, but for other reasons as well.
Okay, Dr. Shreyashi, that was an interesting case presentation. Thank you. We now have the master, Dr. Naveen Jayakumar, to talk to us about visual field, a neuro-ophthalmic perspective in 12 questions, 6 lessons, and 1 plan. What is that?
I think a couple of lessons are already done here, so we'll be rather short. So this is my talk. There are some questions here and a couple of lessons, and what the 1 plan is, I'll come to that, Amitabh. So my first question is, why do you perform visual fields? So we usually perform visual fields if you want to localize a lesion topically. Sometimes we may perform it for differential diagnosis. For example, if you had a swollen disc, is it a central scotoma? That would tell you that it is an optic neuritis. If you had an inferior altitudinal defect, you might say, well, that looks like an NaION. You would like to monitor progression or recovery. For example, if you had papilledema in an IIH patient and you're treating them with Diamox, you'd like to know whether the condition is getting better, are the fields getting better, or the fields worsening. Or, for example, in a compressive optic neuropathy due to, say, thyroid disease, where things can go up and down. So you'd like to use fields for monitoring the optic nerve function. And last but not the least, any cause, any unexplained visual impairment deserves a visual field. But today, I'm just going to talk to you about the first one, which is topical localization. So this is the visual pathway, as you're all very, very familiar. But as far as localization is concerned, we can divide the visual field into 4 distinct regions. The first one is the outer retina, which has the least specific field effect, and you can usually see a fundus lesion that corresponds to the field effect, such as the ring scotoma, for example. Moving a little backwards, you come to region 2, which is the inner retina, which is the ganglion cells, the nerve fiber layer, and the optic nerve itself. So here you get the classic centrocecal scotoma, the altitudinal defects, your glaucoma defects, etc., etc. And of course, then you have right in the center is the optic chiasm, which is very, very characteristic kind of field effects, that bitemporal and the binasal hemianopias and the hemiscotomas. And lastly, you have this entire region at the back, which is a retrochiasmal visual pathway. The hallmark of that, of course, is the contralateral homonymous hemianopia. This region consists of the tract, the LGB, the radiations, and the cortex. And each of these can have slightly differing kind of fields, which may help you to localize the lesions. That's it. These are the 4. Okay? So just keep in mind these 4, and then we will look at some examples of field effects and see where we can use this and localize. Okay? So this is the overview. And so this is my first. I think this is very, very easy. Can anyone tell me what this is? Yeah. So this is a bitemporal hemianopia. So that's all easy, and everyone knows that comes from there. This is a case of a pituitary adenoma pressing on the optic chiasm. Okay, so we have a bitemporal means, bitemporal binasal is the optic chiasm, that's region 3. Okay, what about this? Patient complained of sudden onset difficulty in seeing with my left eye. This is the field. Pardon? Pie on the floor, okay. Why do you say pie on the floor? Is it a quadrantic defect? Could it be something in the retina itself? What is it that is missing here that could tell you that it is a neurological field? There you go. Now what do you see? So you see something which is in the left field in both eyes. So this is some kind of a homonymous hemianopia. Okay? Is it complete? It isn't. Okay? All right. So it's an incomplete left homonymous hemianopia. Let's add one more adjective to it. What about the shape? Is the shape similar in both eyes? You don't? Well, more or less it is, isn't it? This wedge on the top is spared. Okay? And you can see the step-like pattern. This is called a cookie cutter kind of a lesion. It's like the ones you make cookies with. So this is very, very typical of an occipital cortex lesion. This is a congruous defect on the left side. Okay? And this is due to this particular occipital infarct. Okay? So this is a homonymous hemianopia. So we're looking at retrochiasmal. It is congruous. So we're thinking of the occipital cortex. Okay. So first lesson. Perform fields of both eyes. Don't look at one field in isolation. Okay. What about this? Do you agree it's a homonymous or is it a heteronymous? Homonymous, okay. Which side? Okay. What kind of field is this? Those over 50 years can answer this. Okay, this is a Jerams or a Goldman. Swati might remember. She's the only one who's done this, I guess. Okay, so this is pre-automated perimetry. So please remember the outline. Okay, the outline is the field of vision. So what you see on this side is the blind area. So now what kind of defect is this? This is a left homonymous hemianopia. Okay, not a right, it's a left homonymous. And also you can see there, that is the macular sparing. You can see that area is spared. Okay, so just remember, in case you come across a patient with these kinds of fields, just remember the outline contains the field. Okay, right, what about this? What is the first thing you're going to ask me now, since I've told you? Okay. Let me ask you, which eye is this? Field of which eye? Right eye. That's right, because that's where the blind spot would have been. Okay. Where would you think you would get a unilateral field effect, something that looks like this? Right, you look at the optic nerve, or you look inside the eye itself. So this is a patient with a chorioretinal scar. You can see the shape of this lesion corresponds perfectly with the kind of field effect. Okay, so this is the first region. All right. All right. This centrocecal and central, okay, so this is the central scotoma, that is the centrocecal scotoma, easy. This is optic nerve, okay, belongs to this patient who had postneuritic optic atrophy. Okay, what about this? Let me tell you, the other eye is fine, okay. Does it follow some kind of nerve fiber pattern? It does, isn't it? Especially, remember, in those days they used to tell us any field effect connecting to the disc belongs to within the eye. Anything going to the horizontal, to the vertical is the brain, a hemianopia kind of a thing. So this is within the eye, and it's some kind of an inferior defect occupying most of it, but kind of linked here. You would get this like it's like almost like saying this is an NTG which is coming all the way up to fixation. This is a slight variation of the inferior altitudinal defect. This belongs to this patient here. Okay, so you can see that upper disc is pale, the lower part is hyperemic, and the superior pallor corresponds to the inferior defect that you see. Okay, so once again, this is optic nerve. So each area, as you can see, has certain distinct patterns. So this whole thing is a game of pattern recognition. Okay, what about this? You've just seen it before, no? Just now. This is you can feel free, I'm not going to eat you up or something. Huh? Bitemporal? Well done. This is a bitemporal hemianopia. Is it? This is a field of which eye? Right eye. You just saw it in a couple of presentations earlier. Someone raised that point. I kept very quiet. Okay? Okay. This is how you should read it. Okay? Right field in front of your right eye, left field in front of your left eye, and what you thought was a bitemporal hemianopia is actually a binasal hemianopia. Okay, so lesson number 2, view the fields as if you are the patient. Right field on your right, left field on your left, and even when you present, put it up that way. Fundus, of course, goes the other way around. Okay? Okay, most of the causes of binasal hemianopias are these large aneurysms, etc. They're very rare. The more common causes are found within the eye, optic nerve diseases, etc., etc. A lot of these are here. Okay. This is an interesting patient. This is a 41-year-old female patient of mine. In 2013, she had an MRI and had a pituitary adenoma diagnosed as a hyperprolactinemia. So then I've been seeing on 2014, 17, 18, you can see all the fields there. Normal discs, vision is fine, color vision is good. And then COVID happened and she didn't come, and she came a couple of months ago. Vision was 6.6, mild disc pallor this time, and Ishihara was still fine. And this was the field. Okay, what do you see here? This is a temporal defect which is respecting the vertical meridian. Okay, what about the other eye? More or less okay, just a few scattered. But any temporal defect respecting the vertical meridian, keep your guard up. Okay, so here you can very, very nicely see this huge mass here. This is a pituitary adenoma. And what you see on top, sliding down it here, that is the optic chiasm. So there's a kind of a pressure here, okay, on the right optic nerve chiasm junction. Okay, that's the Neo-Willebrand, and this is an example of a junctional scotoma. Now, what I wanted to put up here was the 2018 field I showed you earlier, which you probably missed. And now if you look at it in retrospect, you can actually see a little bit of that defect. Okay, there. So this is a classic Trequez junctional scotoma where you have a normal field. The original description was a normal field on one side and a contralateral upper temporal peripheral field defect. Okay, so remember this, in a unilateral optic neuropathy, the neurologically more important field is the field of the opposite eye, the contralateral apparently normal eye. Okay, don't forget that. Okay. And the second thing is 30-2 or 24-2 or 60 degrees, virtually every field, neuro-ophthalmic field, fits into the central 30 degrees, except possibly the Trequez junctional scotoma because it starts in the periphery. Okay, so keep that in mind. If there is a suspicion, do a 60 degree and take a look at it. Okay, okay, what is this? Sometimes things look confusing, but if you look at it, which side is the lesion? You know, which side is the field defect? You can see more or less it's on the left in both eyes. Okay, it's not a quadrant. Okay, it's not it's incomplete, but it's not a quadrant. It is a sector. Okay, so this is called a sector anopia, and this is due to lateral geniculate body lesions. Now, the lateral geniculate body has got some unusual kind of pattern. Okay, so we'll come to that. But just remember this. As I told you, incomplete homonymous hemianopes you can localize to different parts of the retrochiasmal pathway. If it's complete, you can't really do that. Okay. LGB, I won't go into too much of detail. There are two circulations in the LGB. One from the MCA, middle choroidal, and one from the posterior choroidal. And so if you have the middle choroidal area getting affected, mostly in the center, you get this kind of a pattern. On the other hand, you can get something like this, where the middle part is more or less spared, and you have 4 other sectors getting involved in each eye. So this is called a quadruple sector anopia, and this is due to the other one, the posterior choroidal, posterior cerebral artery circulation. That's a lateral choroidal artery. So LGB has these sector anopias. They can also have incomplete homonymous, but you get this kind of a pattern. Okay, so this again is a lesion in the LGB. Okay. What about this? Someone who's probably hungry mentioned it earlier. Pie in the sky. Well done. Pie in the sky, also known boringly as a superior quadrantopia. Okay. Which side? Left. Well done. So this is due to radiations now. So this is the Mayer's loop. Okay. So temporal lobe, the inferior fibers producing the superior quadrantopia. That's the lesion there for that patient. And this is the opposite of that. This is called a, if you drop the pie, that's where it lands. It's on the floor. And this is due to parietal lobe lesions. Okay, this is a thalamoparietal hematoma. Okay, so lesson 6 is always perform confrontation fields for poor vision. Okay, it's very, very important. We think confrontation, poor vision, you can't do anything, leave it alone. It's not going to contribute anything. It will. Okay, so if you have poor visual acuity, you can't do formal field testing. But even there, even if a patient has got hand movements or counting fingers, you can see whether it's falling in one hemianopic field or not, or is it an altitudinal kind of a pattern or not, and that will help you. If you had a disc pallor and the patient can count fingers on top and not below, you might think this is some kind of an old NAION which has resulted in optic atrophy. If you had the pallor and the patient is not counting on the sides, outer side, able to count your fingers on the inner side, it's a temporal hemianopic field, and that's as significant as a formal field test. Okay? The last, of course, is a left homonymous hemianopia. Hemi-neglect is a lesser understood condition, and for that I've got a video for you. So you can see the lesion here, okay, on the right side. I'd like you to listen to this patient and see what he says. Have the sound.
So you can only see from across there?
Yeah, from there to there. That's my vision.
So what's going on in the other
right side?
Half?
Nothing.
There's nothing at all?
Because often I've come up from this side to give you something.
Anybody
haven't
can
I?
creep up my left, I
And
wouldn't
he
know they were
doesn't
there.
see anything.
I can't sense them.
Which finger moves?
First one. That one.
Okay.
Yeah.
So this is confrontation.
Look at me.
See, he's not seeing on the left side, okay? But now he's moved it both to the
That
seeing
one.
area.
Okay.
Now watch what happens.
That one. That one. That one.
See what happens on simultaneous.
That one.
Okay. That's fine.
The moment you show each thing separately, he's able to make out. The moment you show simultaneous, his brain favors the right, ignores the left. That's a hemi-neglect. Okay? And that's very typical of parietal lobe lesions as well. So here is one very, very useful way in which confrontation fields can be useful. Okay? So this is the plan I was talking about. So if there's a unilateral field defect, okay, or bilateral, so look at it that way. Place the two fields and decide. Okay? Okay, if it's unilateral, it's in the retina or the optic nerve. If it's bilateral, ask yourself if it's respecting the vertical meridian. If it's not, then it's either in the retina or the optic nerve, or it could be a junction scotoma. But if it is respecting the vertical meridian, you're dealing with a hemianopia. So once you got a hemianopia, ask yourself, is it affecting the left hemifields in both eyes or the right hemifields in both eyes, in which case it's homonymous. If it isn't answering that question correctly, then you ask yourself, is it affecting the temporal hemifields or the nasal hemifields, in which case you're dealing with a heteronymous hemianopia, which is bitemporal or binasal. If it is homonymous hemianopia, is it complete or is it incomplete? As I told you, if it's a complete homonymous hemianopia, it's non-localizing. All you can say it is retrochiasmal on the opposite side. Whereas if it is incomplete, then you get patterns. You can get sectors, you can get incongruous, you can get quadrantopias, and you can get exquisitely congruous ones in the occipital cortex. Okay? So this is how you can approach a visual field defect. I hope things are slightly clearer. Thank you.
Thank you, Dr. Naveen Jayakumar, for that excellent way you made visual fields look so simple. The topic is open for questions and discussion.
Sir, for the general ophthalmologist, what is your take regarding the field of vision 30-2 or 24-2 or anything?
I think I normally do a 30-2 for every neuro-ophthalmic field. It's very, very rare I would do a 120 screening. In the US, most of the neurologists are just doing a 24-2 CETA-FAST. That's it, because it saves time. The only reason I do a 120 screening is sometimes you just have patients on whom there is a very low chance of having a field defect. For example, a patient with headache with normal vision, you're not too sure, they said something is going on in their vision, or temporarily sometimes I can't see. You just want to make sure. These are patients with a high probability of having a normal field. And you just want to screen them. So as a screening, a 120 screening is faster, it's easier to do. You don't need a threshold for that. The spot size is usually 30-2 is stimulus size 3, unless the vision is very poor. That way. Color fields, I really stopped doing color fields now, because most of the information we get by this itself, that way. There is a role for a 10-2. Sometimes you can have a field defect which is on a 30-2 patient complaining of some vision problem. There's a dot in the center. Okay? If you magnify that from 30-2 to a 10-2, there is a patient who actually had a very small hemiscotoma. You did an MR for him and he had a small occipital infarct producing that. So 10-2 can sometimes work if you're in doubt and you want to magnify that area on the 30-2, 10-2 will help.
But would you advocate doing a 10-2 in all neurophthal cases in addition to a 30-2?
No.
Sir, one question. For a glaucoma progression, what is the interval we should go for regular field analysis?
I will happily pass the mic to the specialist.
Dr. Alakesh, anything you want?
It would depend, sir, on many factors, individualized patient to patient. But maybe 6 monthly to 1 year, if you have actually done the first 5 fields in the first 1.5 years, and you have got a robust, VFI. But in some cases where you are not sure about the progression, you cannot really go to that extent of perhaps doing it 3 times in 1 month. But maybe you can, in our circumstances, maybe repeat it at 2 to 3 months interval if you are really suspecting a progression before changing your course of treatment in that patient. Again, it would depend upon the extent of damage, the age of the patient, and many other factors perhaps.
Yeah, I thought today is Neuro Ophthalmology. But yeah, we can have a discussion on sometime later on glaucoma, maybe. Yeah. Any other questions?
I just wanted to ask, sir. Sir, your 30-2 is, rule would be valid for some patients who are sent to us by the neurosurgeons to do field because they have a pituitary adenoma without any visual problems. So normally we do a field before they do the surgery and then for post-surgery follow-up. So all these fields would be 30-2 ideally, sir?
It depends on, for example, if you are already suspecting a field defect, like you know that, for example, if the patient is, has a pituitary tumor and they've sent it to you, and you are thinking, well, one is going to expect some kind of a bitemporal hemianopia possibly. I think there, when you're already expecting some kind of a field defect, it is good to quantify and know how bad that defect is. Whereas if it's something very, very general, you really don't need to do, as I told you, low chance of a defect, then you can skip it. But especially for surgeries, like why would a neurologist send it to you unless he wants to see pre and post, in which case a screening may not be sufficient. You may need to know more information.
And sir, in that case, if the patient comes back after surgery, maybe about 3 months when the patient is doing well, maybe we repeat one field. So after that follow-up, we usually follow yearly. Do you think it is okay, or would it be like, unless and until the neurosurgeon tells us that you do it again?
May I ask Dr. Nazneen to come and start setting up your talk, please?
Yeah, Nazneen, do come. There is no hard and fast rule. I think it all depends on individual case-by-case basis. Sometimes pituitary adenomas, sometimes surgeons leave behind. There's a fair bit of residual tumor and things, and there's some suspicion that again there's a pressure, and you may need to do fields more frequently. At other times, it's all fine. Vision is improved. Even the temporal hemianopia itself is cleared up half of it. So then maybe after 6 months or 1 year is sufficient.
Okay. Thank you.
Okay, we now have a talk by Dr. Nazneen Nazam. She is a consultant at ESI Hospital, Joka, and she'll be talking to us on amyloidosis, fugax.
Good evening to respected seniors and my colleagues. So my talk is transient visual loss. Don't turn a blind eye to transient blindness. So I'll be talking very briefly about 2 cases. Now my first case is a 60-year-old male. The intern took the history that the patient had complaints of flashes of light in both eyes, visual acuity plano 6/6 for distance, and near was N6 with correction. There was no attendant on that day. So the patient was asked to come the next day with an attendant for dilated examination. However, I'd like to point out here that there are some red flags here. Flashes of light in both eyes in a 60-year-old male is a little bit unusual, and someone who's also not a high myope. So the next day the patient came and he was dilated. So when I examined him, the examination was completely normal. And just as I was about to ask the patient to accompany me to the dark room to do indirect ophthalmoscopy, I thought just let me once ask him, is he having flashes of light in both the eyes? And that is when he told me that he wasn't having flashes of light, he was having blackout of vision. So the blackout of vision was lasting for a minute or more. It was painless. It was irregular in occurrence, and it was he was experiencing it off and on since the last 2-3 months. So an important point here is take time out to take the history yourself and encourage the patient to describe the symptoms in his or her own words. So there was no positive history except that the patient had history of migraine, but he was not taking any treatment. Apart from that, he was neither a diabetic nor a hypertensive, didn't have any cardiac disease, but he was a smoker since the last 30 years. There was no history of limb or facial weakness, no history of slurring of speech, altered sensorium, fever, weakness, scalp tenderness. And it is important to ask a patient of transient loss of vision or amaurosis fugax about the symptoms of transient ischemic attack or stroke, because amaurosis fugax patients can later have stroke. Also, giant cell arteritis can present as amaurosis fugax. This is important because TIA can be a harbinger of stroke, and we know stroke is one of the leading causes of death in the elderly, and in every 3 minutes, one person dies of stroke. Also, giant cell arteritis can present as amaurosis fugax. So ocular examination was completely normal, visual field was normal. So it is important, I would like to say here that it is important to do a dilated funduscopy in all such patients of amaurosis fugax to look for retinal ischemia or to look for features of CRVO or Hollenhorst plaques or CRAO. Most cases of amaurosis fugax have normal fundus. However, do not conclude that your patient is normal just because his ocular examination is normal. So the systemic examination patient was hemodynamically stable. It is extremely important to do a cardiovascular examination in such patients, and do not miss to auscultate the carotid artery in such patients, because a carotid stenosis can produce a bruit, which you can hear with the diaphragm of the stethoscope, and the more tighter the stenosis, the sharper is the bruit. The routine investigations that I advised were all normal, except that the lipid profile was slightly deranged. I advised an ECG urgently, an echocardiography, and of course an urgent carotid Doppler. Now, carotid Doppler is very important in patients of amaurosis fugax to look for carotid artery stenosis and to see the extent of the carotid artery stenosis. Other than that, you can have other things like calcified plaques, atheromatous plaques, or even carotid artery dissection. So in the interim, while the investigation reports were received by me, the patient was also referred to medicine, where they elicited a history of syncope, and other than that, the patient was neurologically stable. They advised the same investigations that I had, and they added an NCCT brain and a 24-hour Holter monitoring. So ECG revealed left ventricular hypertrophy and T-wave inversion. 2D echo was essentially normal, ejection fraction was also normal. 24-hour Holter monitoring was also normal, there was no arrhythmia. It is important to look for atrial fibrillation in patients who present with amaurosis fugax. Now coming to the carotid artery Doppler. So it showed intimal thickening along with calcified plaque, seen at bilateral bifurcation more in the right than in the left eye, extending to the proximal internal carotid artery. And you see there are plaques with ulceration causing narrowing of the internal carotid artery at origin. So you see there is stenosis, there is ulceration. The extent of stenosis was 50 to 69%. Now this is very important because asymptomatic patients who have up to 70 to 80% stenosis, these patients may be observed, but patients who are symptomatic and have greater than 50% stenosis, they need to go an intervention. That is, of course, best decided by the CTVS surgeon. There are two types of intervention, carotid artery stenting and carotid end arterectomy. So for the cardiologist advised a carotid CT angiogram, and the CT brain was normal. I'd like to add that CT brain is important in such patients to rule out any hemorrhage or infarction or stroke or TIA, whatever. So the patient was sent to CTVS surgeon and he was started on ecospirin and atorvastatin. So this is the carotid CT angiogram. As you can see that the entire thing is bold, is highlighted because the patient had severe atherosclerotic calcification in aortic arch, 80% stenosis in the right brachiocephalic artery, 10 to 20% stenosis in left common carotid artery, diffuse calcific plaques, mixed plaques, and a lot of stenosis and external carotid artery almost near total luminal occlusion. So the patient was referred to neuromedicine for consideration for digital subtraction angiography, for better delineation of the cerebral vasculature, for the aortogram of arch of aorta and its branches, along with the peripheral angiography. Now, because aortogram of arch of aorta is an invasive procedure and carries a high risk of mortality, ultimately the patient was taken up for peripheral angiography. Peripheral angiography revealed a minor plaque at the origin of right common carotid artery. Therefore, because the patient was asymptomatic and because there was a minor plaque and the stenosis was not greater than 80%, therefore ultimately this patient was advised medical management. So he was advised there was no major stenosis, and the patient was asked to continue aspirin and atorvastatin. So this is the flowchart for carotid artery stenosis. Or patients presenting to you, to an ophthalmologist with amaurosis fugax, do a carotid artery Doppler, and then see the extent of the stenosis. If the patient is symptomatic and has a stenosis more than 50%, or if the patient is asymptomatic, has a stenosis more than 70 to 80%, then the patient likely needs intervention. The interventions are two, like I said, carotid endarterectomy or carotid artery stenting. If the patient is asymptomatic and has less than 80% stenosis, then you can take the patient up for conservative management. So these are the carotid endarterectomy and carotid artery stenting. So my second patient who came with transient visual loss was a 22-year-old female, our own MBBS student who came with headache and blurring of vision for last 2 days. And she described her vision loss as light going off, like electricity, like it goes off and it's completely dark and comes, then again goes and again comes, like that. So the term that struck me was transient visual obscuration. She was her weight was little on the higher side. She was not obese, but her BMI was a little high. And she gave history of taking oral contraceptive pills for her PCOD. So fundus examination, pupils were normal. There was no RAPD. Fundus revealed bilateral disc edema. So the patient profile, along with disc edema, along with headache, along with a history of oral contraceptive intake, and slightly higher body weight, it suggested one diagnosis to me, that is idiopathic intracranial hypertension. So I advised MRI brain plus orbits. She was a student. She didn't get the MR venography done. She got the MRI done. Perimetry was normal. VP was advised by the neurologist, which was again normal. So this is the MRI brain and orbits. Orbits was, it showed partially empty sella and features of idiopathic intracranial hypertension. So in conjunction with neurologist and the diagnosis being idiopathic intracranial hypertension, we started the patient on tablet acetazolamide BD. She took it for 4 to 5 months and her headache was relieved and the papilledema disappeared completely except for some mild residual pallor. So my take-home message is take detailed history and take it yourself. Do a basic cardiological and neurological examination. Never ignore transient loss of vision just because the vision became normal after a few seconds or minutes or hours, because such patients can go on to develop TIAs or stroke and they have a high risk of mortality. Consider the patient profile, take a complete history, do a complete examination, including a neurological and cardiovascular examination. This is mandatory. And refer the patient as appropriate to a cardiologist or neurologist or a CTPS surgeon or to a neurosurgeon. Amaurosis fugax can herald something sinister and fatal, such as stroke. Prompt referral can even avoid fatality. Transient visual obscuration often points to a neurological cause. It can cause a loss of morbidity, for example, idiopathic intracranial hypertension, and should the cause for papilledema be a tumor, then it can even be fatal. Thank you.
Excellent presentation. We do come across with so many cases of amaurosis fugax. There is one senior, Dr. Devashish Datto, who also got similar case nearly 6 months or 8 months back. And the patient went to Hyderabad. Na? What was the ultimate diagnosis? Huh? What was the diagnosis?
Carotid artery.
So most of us, we feel that this should be referred immediately to the cardiologist for total evaluation of the case, cardiological workup.
Exactly.
And also neurologist or neuro ophthalmologist
Yes, yes.
also. Thank you.
Dr. Alokesh, would you like to say something? Okay.
One thing, the MRV should have been
Exactly.
should have been done.
Should
More so because she's an MBBS student.
Yeah.
Why the need for MRV should have been imposed.
Actually, she's a hostler. For the investigations, she went to Lucknow and then she came back. Half her reports are there, half are here. And I advised an MRV, but she got an MRI done just.
Yeah, but it needs to be impressed upon that.
I get MRV and MRI done in all patients of IIH.
I think
just one thing it reminded me, I just wanted to share with you, is one case I remember some about 8 years ago. It was a reverse referral to what Sir was referring to. This young girl, she had a headache and she had the neurologists at the the Institute of Neurosciences, Kolkata, had seen her and they had seen papilledema. And they did the whole gamut of investigations. Okay. And they couldn't find anything. And then as a last resort, they sent to us. Then okay, we saw everything, every data. Then somehow the papilledema looked very discrete. There was no, the nerve layer edema surrounding the discs. And then we did a B scan. And we had bilateral optic nerve occlusions, and the cause of the headache was fusion deficit. Convergence and fusion deficit. So very rare, but works the other way around.
Madam, I ask you one question. Have you ever came across with a case presenting with similar complaints, but nothing came from any investigation, and the diagnosis was malingering? I got
No,
a case.
I have. Acha.
I got a case, and there was no neurological problem. The cardiologist also told there is nothing was there, and ultimately the vision came back, and it was a psychiatrist told that it is purely psychogenic. One case I got.
Near about 50% of the CRO, full-blown CRO patient, if you ask them very precisely, either of them, they have appreciated a history of amaurosis fugax. 50% of CRO patients.
Yes.
Okay, Nazneen, that was a good presentation. Thank you. May I invite Dr. Oindrila Roy, who's a senior resident at RIO, to present her presentation on an overview on clinical approach to a case of non-glaucomatous optic neuropathy.
Good evening, everyone. My topic for today is an overview on the clinical approach to a case of non-glaucomatous optic neuropathy. I shall be presenting a few cases. Now, we all have realized by now that not all optic discs which have cupping are having glaucoma. Some of them have underlying non-glaucomatous causes. Now, the pointers which will point us to a correct diagnosis is having a detailed history, a careful examination, and certain investigations to aid our diagnosis. Usually we see that the age is of a younger group in case of non-glaucomatous optic neuropathies. A family history may be present in certain cases of non-glaucomatous optic neuropathy and many cases of glaucomatous optic neuropathies. Now, associated neurologic endocrine symptoms, a pattern and chronicity of the visual loss must be taken. Past medical and surgical histories are also very relevant. Now, the careful examination, we should have in all atypical cases of findings of the disc parameters, we should have a high level of suspicion if the case could be a non-glaucomatous cause. Here we must evaluate the color vision. A red-green color blindness may be present in case of non-glaucomatous causes. Scrutiny of the optic disc and visual field changes which are atypical should tell us that it could be a non-glaucomatous cause. Now the investigations, MRI are of course an investigation of choice. OCT, as I shall be discussing later, will also might aid in the diagnosis. Here are a few cases which had presented to our outdoor. The case 1, he was a 49-year-old man with visual acuities 20 by 20 and 20 by 100 with RAPD and altitudinal scotoma. The left eye had inferior swelling of the nerve fiber layer. He was a known hypertensive, and on investigations we found hypercholesterolemia as well. We made a diagnosis of ischemic optic neuropathy, the non-arthritic variety. Over time, we have realized that if on follow-up, the patient can present with cupping, but the distinguishing feature is always a pallor which is out of proportion to the cupping. Now, these were the fields for the patient. The next case was a 42-year-old woman who presented with decreased visual acuity and a relative afferent pupillary defect. The IOP was normal. There was decreased color vision. The visual fields were inferior altitudinal defect with a superior arcuate defect involving the central vision. The central foveal threshold was also diminished. Both optic nerves had an increased cup to disc ratio, but the right disc also had optic atrophy. Now the keynote which told us to do an MRI was the optic nerve appearance with pallor out of proportion to the cupping, the color vision loss, and a predominant unilateral vision loss. The MRI was done, and later it was found to be a optic nerve sheath meningioma. Unfortunately, I don't have the MRI of this patient. The next case was a 48-year-old man with vision loss in the left eye of hand motion and 20 by 40 in the right eye. There was a left RAPD. On fundus examination, there was an increased cup to disc ratio in both the eyes and marked pallor of the left disc. The visual field showed a superior temporal defect on the right with diffuse loss on the left. The MRI showed a compressive intracranial mass lesion in the area of the chiasm. We have sent the patient for to the neurosurgery, and the tissue diagnosis is still awaited in this patient. This was another patient who had bilateral pallor of the discs. Another case, it was an 18-year-old boy who presented with 20 by 60 in the right eye and 20 by 80 vision in the left eye. He had come earlier with an involvement of initially one eye followed by the other eye. The first time when he presented to us, we thought it was a case of optic neuritis, but when he came with the involvement of the other eye, a poor color vision, we took a family history. We took a family history which was suggestive of a hereditary cause. This was diagnosed later to be a case of Leber's hereditary optic neuropathy. We still don't have the genetic markers for this patient, but most likely it could be a case of Leber's hereditary optic neuropathy. The patient did not have any substance use history also. Now, when to do imaging? When we have a younger age group presenting with atypical symptoms, asymmetric involvement, atypical visual field patterns that we have seen, that either it's a bitemporal field defect, not the typical ones as found in glaucoma, then we should go for an MRI. An atypical optic nerve appearance, which we have already said many times, that pallor will be out of proportion to the cupping, then we should go in for an MRI. These are two other patients. One had a pituitary adenoma and the other one had an optic nerve glioma. I just have the MRI of these two patients. Now, there are studies which have shown the role of OCT in non-glaucomatous optic neuropathy. It is already established that there is a role of OCT in aiding the diagnosis of glaucomatous optic neuropathy. In non-glaucomatous optic neuropathy, it has been found that for a similar average RNFL, the patients with non-glaucomatous optic nerve cupping had lower nasal and temporal RNFL thickness, as well as lower macular thickness and volume compared to patients with glaucomatous optic nerve cupping. Now to summarize, in case of a glaucomatous optic neuropathy, usually the patient will be of an older age group presenting late because the visual field obscurations are usually occurring late. If it is in a young patient, it can be either a developmental or a secondary cause. They often remain asymptomatic until the late stages, the visual acuity being preserved until the very late stages. There is visual acuity and color vision are both maintained until the late stages. mostly it's a symmetric disease in case of a POAG. So if there is a worse eye in the that eye might elicit RAPD. Otherwise, RAPD will not be present. The visual acuity and optic disc cupping, the central vision might be preserved despite an advanced optic disc cupping. And the typical visual field defects in glaucomatous will be nasal step, arcuate defects, etc. And the laterality, it is usually a bilateral symmetric disease. In case of non-glaucomatous optic atrophy, usually a young middle-aged person will be presenting with a sudden, rapidly progressing visual loss with associated neurological symptoms such as headaches. Relative early loss of visual acuity will be found. Central vision will be lost. Now, color vision loss will parallel the reduction in the visual acuity, and usually they will have a presentation of ipsilateral RAPD. Visual acuity is poor compared to the optic disc cupping. These are the types of visual field defects, that is central, centrocecal, altitudinal, bitemporal, hemianopry, depending on the cause, which will be respecting the vertical meridian as we have already seen. Often it is unilateral with asymmetric optic neuropathy. The laterality is usually unilateral. So this brings us to the end of my talk.
Thank you, Dr. Vendrila. That was a very exhaustive and complete discussion on the subject. If there is one take-home message, can you summarize one take-home message and then we can...
To have a very detailed evaluation of the disc, it is very important to do fields, and it is very important to have a high index of suspicion. If we do not think about it, we will not see it.
Excellent. Thank you very much. We will go on to our next topic on neuroradiology in ophthalmology. It was supposed to have been delivered by Dr. Shukalan Purakayastha, but apparently he is not keeping well. And on his behalf, Dr. Bapi Burman, who is a consultant radiologist at Institute of Neurosciences, Kolkata, he is going to talk to us on this topic.
So I will just show some cases with mainly imaging, and we'll discuss about the cases and their imaging. So this is a child who presented some with left eye vision problem. So this is the you can see this is the T1 axial T1 image. This is the axial T2 image, and these are the sagittal T1 at the level of optic nerve. And so here you can see that we can see posterior to the optic globe. We can see a defect, and this defect is in the midline and is contiguous along the optic nerve. So this is a case of coloboma with defect in the posterior wall of globe. You can see the optic nerve arising just at the center of the defect. This is another case with a child with gross developmental anomaly with left eye vision problem. So you can see that this is the sagittal T2 scan. Here we should see corpus callosum here, but we are not seeing the corpus callosum. So there is agenesis of corpus callosum, and we can also see in the coronal T1 that the corpus callosum is not present. Both the white matter tracts are ending abruptly in the parasagittal plane, and we can also see that left eyeball is small, along with non-visualization of the left side of optic chiasma as well as optic nerve, optic tract. So this is septo-optic dysplasia, which is malformation. This can be associated with other malformation also. This is a case. The patient that is you can see that there is a lot of swelling in the right orbit along with proptosis. The patient is acute presentation with along headache, vision problem as well as proptosis. So we can see that there is a small T2 hyperintense lesion in the just superior to the right eyeball, which is showing peripheral enhancement. And there is also enhancement of the adjacent soft tissues. You can see that this lesion is showing, appears, there is also defect in the frontal bone, frontal sinus, which is also enhancing. Also there is some enhancement. This is in the intracranial dural. So this is a infective pathology. Both involve, there is formation of a orbital abscess, frontal sinusitis, along with subdural abscess formation. So this is an invasive kind of pathology. Next case, this is a case of TB. Here you can see that this is a coronal T2 and coronal T1 post-contrast, and also sagittal T1 post-contrast. You can see peripherally re-enhancing lesion in the right-sided suprasellar system, which is also, this is compressing on the optic chiasma, and we can see enhancement of the optic chiasma. So this is causing field defect on the, because of the compression over the optic chiasma, along with adjacent opticochiasmatic meningitis. So case of tuberculoma. This is a case of neocystic This is the B scan. And the B scan, here you can seeing a small cystic lesion with an eccentric echogenic dot in the posterior wall of the eyeball. And in the same patient, we found a ring enhancing lesion in the brain on the left side with some peripheral calcification. And most importantly, there is a small black dot inside that cystic lesion. That is the scolex. So this will suggest that it is not a tuberculoma, it is NCC, along with ocular cysticercus. This one is multiple neurocysticercosis disseminated. So we can see there are multiple cystic lesions with central dot, which is classical, and these lesions are so disseminated. We can see in the tongue. This is the tongue. You can see in the paraspinal muscles. These scolex have characteristic T1 hyperintensity, because they will show T2. Hypo means it's dark, and hyper means it's bright. So we can see the central bright spot on T1. It is characteristic of NCC. This is a case of multiple ring enhancing lesions. You can see one lesion here in the temporal lobe, one lesion here in the cerebellum. And along with that, what we have seen, that this is the non-contrast T1, this is post-contrast. Where we can see this is the optic chiasma. So there is enhancement of the optic chiasma along the pial surface of the optic chiasma, extending to the optic nerves. So there is optical meningitis along with local exudates formation in the suprasellar system. So this is a case of tuberculoma. In tuberculosis, we see generally extensive meningeal involvement. You can see this meningeal enhancement. Along with this can involve the usually in most patients we see basal exudates which are involving the optic chiasma. They usually present with some visual defect. Here you can see that there is a large, this is the T1, axial T1 post-contrast. You can see a peripherally enhancing irregular mass-like lesion in the sellar suprasellar system, which is even going up to the third ventricle, up to the foramen of Monroe. So here optic chiasma we are not seeing. It is so much compressed and displaced that we are very difficult to identify here. So patient will present with central, because of the central compression on the optic nerve, optic chiasma, there will be bilateral the defect, field defect. And this case actually came out to be a abscess in the sellar and suprasellar region, which is most probably tubercular. This patient came with left-sided multiple cranial nerve palsy, and we can see that this is the axial images on the sequential sequence. This is the at the level of just posterior to globe. You can see these optic nerves here, and this is there at the level of just anterior in the orbital apex. You can see there is a heterogeneous enhancing thickening along the involving the left cavernous sinus, left optic orbital apex, and along the extracorneal compartment of the left orbit, which is not seen here. This is the normal lateral rectus enhancing. So you can see this enhancing thickening, which is closely abutting this extraocular muscles, as well as this in the optic orbital apex. So this is a case of Tolosahad syndrome. Is usually we will see this. This is inflammatory pathology, as well all know. This is another case. So these patients present with multiple cranial neuropathy, along with vision, bilateral third and bilateral cranial nerve, third, fifth, and other cranial nerve also was there. So on MRI, this is the all post-contrast images, the parietal and axial. You can see there is a leptomeningeal enhancement along the brainstem, enhancement along the optic at the chiasma, along the optic tracts and optic nerves bilaterally, along the bilateral trigeminal nerve rootlets. So this type of enhancement, this diffuse leptomeningeal enhancement and enhancement of optic nerves, we should think of two possibilities. This can be a tubercular leptomeningitis, or this can be a carcinomatous leptomeningitis. If along with this, if we see some nerve thickening, then we should also think of other possibilities like sarcoidosis or NF2. There will be multiple nerve thickening. So this patient came with bilateral hemianopia. So this, you can see there is a small isointense lesion. This is the T1 sagittal and coronal, and T1 post-contrast. So isointense lesion in the sella with some extension into the supracell system, causing compression over the central part of optic chiasma and displacing it superiorly. On post-contrast, this actually it's not enhancing. The adjacent compressed pituitary gland is enhancing. You can see the periphery. There is enhancement of the pituitary, but not much of enhancement of this lesion. So in this case, one possibility is pituitary adenoma, and which is and another is Rathke-Cleft cyst. This came out to be Rathke-Cleft cyst because this cyst, content of the Rathke-Cleft cyst can be variable. They can show variable signal, but main important is the pituitary gland should be visualized separately from the lesion. This is a case of giant or pituitary macroadenoma. Patient had multiple cranial nerve palsy on the left side because this lesion is infiltrating in the left cavernous sinus. This is the left cavernous ICL, which is completely enclosed by the lesion. And also patient had bilateral visual field defect because it is also a part in the supracell system is causing compression over the optic chiasma. These type of tumors we usually very difficult to treat. They usually recur even after surgery as well as radiotherapy. This patient came with sudden onset visual disturbance on both eyes, and so here you can see this is the T1 image, and this is also sagittal and axial T1. We can see T1 hyperintense lesion in the sella and supracellular system. So T1 hyperintensity, we should always think of blood. So there is a hemorrhage in the pituitary gland. So case of pituitary apoplexy, because of the mass effect of the hematoma, It is causing compression over the optic chiasma and bilateral vision defect. This is a young adult patient who presented with gradually progressive bilateral visual field defect. So in this patient, we can see that this is the axial T2, axial flare T1, and on the coronal T1. We can see this cystic lesion with a eccentric solid nodule in the suprasellar cistern. This cystic lesion is not suppressed on the flare cystic part, but it is on T1. It is slightly more intense than the CSF. This came out to be a pilocytic astrocytoma. So any lesion with cyst with mural nodule in this region, we should think of pilocytic astrocytoma, or other differentials can be, in this case, a germinoma or craniopharyngioma. This patient is a case of basifrontal meningioma. So we can see there is a this is the parietal and coronal image. You can see a extraaxial lesion, dural-based lesion on the anterior basifrontal with adherent, which is adherent to the anterior falx cerebri, and it is causing compression over these. There is compression over the optic chiasma from above. These patients had multiple bilateral cranial neuropathy with vision problem, and on imaging we can see there is a large heterogeneously enhancing mass in the clivus with involvement of the bilateral cavernous sinus, pituitary, as well as in the sphenoid sinus. This lesion is causing infiltrating bilateral cavernous sinus, so multiple cranial neuropathy can be explained, and also causing compression over this optic chiasma and bilateral optic nerve in the orbital apex. This lesion, as you can see, that this is infiltrating lesion. So in the adult patient, we should this can be up to the differential can be either metastasis in the clivus, or another is chordoma. But in chordoma is usually homogeneous solid lesion, not much of any heterogeneous component seen. So it came out to be metastatic lesion. This axial T1, coronal T1, T2 axial, and T1 coronal. We can see that there is a cylindrical lesion involving the optic nerve. This lesion, this is on seen on T2. The optic nerve is not seen separately. The optic nerve is completely replaced by the lesion. So this is, and you can also we can also see there is a defect in the superior orbital fissure. So there is a sphenoid dysplasia along with this optic glioma. This is optic pathway glioma along with sphenoid wing dysplasia, classical of neurofibromatosis 1. If we see the optic nerve encased within the lesion, this another that differential would be optic nerve sheath meningioma. This is the same another case of NF1. In the here we are not seeing any optic pathway glioma, but we can see that there are multiple signal alteration in the bilateral globus pallidus, thalamus, as well as in the brainstem and cerebellar white matter. We call it focal FACI lesion, focal altered signal alteration. And we can see that this side of sphenoid wing is dysplastic compared to this side, and there which can have an resultant proptosis on the right side. This is a case on of right-sided. This patient came with right-sided third nerve palsy. So, along with proptosis, you can see that there is a lesion which is a little bit elongated, homogeneously enhancing in these post-contrast images. This is the post-contrast image. What we can appreciate here that the optic nerve is seen separately from the tumor, and it is displaced medially. The lesion appears to be having intracranial extension along the superior orbital fissure. So this is a case of third nerve peripheral nerve sheath tumor, that is schwannoma or neurofibroma of the third nerve. Here we can see that this is a case of bilateral patient of bilateral globe. We can see that there is enhancement along with of the bilateral globe. Here you can see this is the post-contrast and pre-contrast, and we can see that left-sided lens is displaced and it is fallen into the vitreous cavity. So bilateral panophthalmitis with left-sided displaced amount of lens. You can see a lot of inflammation in the periorbital also. This patient came with left-sided orbital swelling and proptosis, which is painless, slowly progressive. On imaging, we found this is the axial T2, axial T1, and this is the post-contrast axial coronal T1 and pre-contrast coronal T1. We can see that there is a lesion in the left orbit, which is both mixed signal intensity. We can see what we can see that it has contained a fluid level. So it has contained two type of content. One is blood and one is fluid. Along with we can see blood fluid level. So this is a classical case of GCT of left orbit. This is another case which patient came with left-sided facial swelling along with some hemangioma in the forehead on the left side, and patient had on imaging had a large retrobulbar lesion, which is both mainly cystic. On post-contrast, what we see that the lesion is very extensive, which intracranial leptomeningeal extension. Along with this is the GRE image, which will usually show calcification and hemorrhage. So we can see that subcortical calcification can be seen, and some leptomeningeal enhancement here and here. So this is case of complex cerebrofacial arteriovenous metameric syndrome. Some variant is we call Sturge-Weber syndrome. So where we can see there is multiple meningeal angioma along with cavernous angioma of the left orbit, along with some brain subcortical calcification. This patient came with orbital swelling, which is intermittent and increases during Valsalva and lying down. So this is on the BBA scan. You can see there is a hypoechoic lesion on the lateral aspect on the left side. On Valsalva, which got sizes increased and along with result into proptosis. So this is case of orbital varix, which we classically can be demonstrated only on Valsalva. Now, normally we can miss it. If we have any strong suspicion, we should always examine these patients after doing imaging, always after Valsalva. This is a case of we can. This is a case of left-sided direct. The patient came with the left-sided proptosis, and this you can see there is multiple dark flow void and around the in the left orbit. This is actually dilated supraorbital vein, and we can also see some intracranial flow voids around the brainstem and superciliary system. So this case was a case of carotid cavernous fistula. This is a case of optic neuropathy. What we found usually find in optic neuropathy is that there will be enhancement of the optic nerve. This is the non-contrast. This is the post-contrast. We can see that we are not able to see properly here, but in the post-contrast we can see there is enhancement of the perioptic nerve sheath. On post-contrast there is dot-like enhancement on the center of the retroorbital region. So this is case of optic neuritis. This I think this is on the sorry. Now coming on to this carotid cavernous fistula, which is usually our main domain of intervention. So this can be classified as direct and indirect. On imaging, we should, in clinical examination, we always find in direct fistula, usually should found a pulsatile proptosis, and on imaging, we usually find that in MRI, there will be left supraophthalmic vein appears dilated, which giving lots of flow void along with proptosis and left orbital swelling. This is a case of another case of CCF, where you can see left orbital proptosis along with the multiple flow voids in the left cavernous sinus region, which are dilated, engorged, along with the extending dilated supraophthalmic vein. This black line.
Dr. Burman, Dr. Burman, sorry to interrupt.
Yeah. Just
okay, you can summarize.
Yeah.
We are running short of time.
So this is a case of direct CCF. This was the image taken before operation, and after embolization, this is the result. So this is a case of CCF, which we are embolized. You can see that this angiogram, carotid angiogram. You can see that there is filling of the supraophthalmic vein, cavernous sinus. So this is direct CC fistula on the right side, which we treated with a balloon placed in the cavernous sinus through the defect. Then we usually encounter multiple aneurysms causing cranial third nerve or sixth nerve palsy. So this is a case of ruptured parapicum aneurysm. This is the aneurysm. This is the posterior communicating artery. So this location usually is the location of the third nerve. So usually patient present with left-sided third nerve palsy on the side of aneurysm. And this is the large supraclavicular aneurysm. Supraclavicular aneurysm, when large, they can cause compression over the optic chiasma from lateral side, and they could produce visual field defect. So this is another case of large supraclavicular IC aneurysm, which was coiled. And this patient with visual field defect, but after coiling, the visual field defect did not progress. It became stationary. This is another case of cavernous IC aneurysm, which cranial nerve neuropathy palsy was there, which was coiled with treated with simple coiling. And this is the last case probably. So this is a case of idiopathic intracranial hypertension. We can see the imaging features here. You can well seen. Bilateral optics nerve sheaths are dilated, tortuous, along with this empty sella. You can see this tortuous optic nerve with some flattening of the optic nerve disc. And on MR venogram is found that there is a bilateral stenosis at the level of transverse and sigmoid sinus junction. This patient was done, angiography was done we did a DSA venogram first to confirm the level of the stenosis, and we then measured the gradient between at the level of stenosis. What is the gradient? If the gradient is more than 10 millimeter of water, then it is significant. So we placed a stent in the transverse and sigmoid sinus, and post stenting the sinus got patent, and the visual symptoms got settled. Thank you.
Thank you, Dr. Burman. Your talk was superb and of a very vast topic, and shows your in-depth understanding of the subject as well. Thank you very much.
Thank you.
We'll move on to the next topic, again by Dr. Naveen Jayakumar. And the audience is allowed to have cross diplopia. You can have one eye on the slide, another on the dinner.
I would seriously encourage that. Feel free to pick up some food and come and sit down. Right, so my final talk today, business-wise, is Dangerous Diplopias. And this is not my title. This was a title given by one of the ophthalmologists at Manipal, I think, when they wanted her to give us a talk. So she made all the talks extremely dramatic, and this was the title of mine. So who needs a scan tonight? Okay, so, well, here goes. So I'm just going to talk on 10 situations or 10 ideas that I'd like you to hold on to. The first is very simple. Monocular versus binocular. You all know that monocular is within the eye. It's not life-threatening. Okay. If it's binocular, then you are in a whole different zone. So cranial nerve palsies is one of the options, and it could be associated with life-threatening conditions. So this is the number one thing that you always do. Is it monocular or is it binocular? The second one, always point to remember, is urgency. Severity and tempo, the speed at which things develop, is basically equal to urgency. Symptoms may be severe, or if they are of sudden onset, or if they are of rapid progression. These are more alarming than changes which are very, very slow, or changes which are intermittent. Okay? So here is one case, 75-year-old male, double vision occasionally since 1 month, with a drooping of the right upper lid since 1 week. Occasional right-sided headache. Take a look at the vision there, 624 N18. The eye movements look full, no diplopia, both pupils are equal in size, etc. So is this cataract versus visual acuity, you know? So how do you make out that? And one of the things is, of course, if you have asymmetric vision, is always to check the pupils for RAPD. Okay, I mentioned that earlier. If there is ptosis, is it fatigable or not? In this case, it is not. What about the speed at which the eye moves? Those is called the saccadic speed. And in that, we found a subtle adduction deficit in the right eye. Okay, so moving on, patient was advised multivitamins and review. And when there is double vision, when there was double vision present, 3 days later, the patient comes with NPL. Okay. Now there is a total third nerve palsy. The pupil is, of course, now you can see anisocoria, which is developed there, here. Okay. Slit lamp, of course, just shows the same cataract. Fundus is normal still. Okay. So MRI brain, no aneurysm, and this is the MRI. What do you see here? A complete enhancement of the entire optic nerve. Okay. Patient had right temporal headache. The temporal artery was swollen. You know where I'm going. This is a patient with giant cell arthritis. Please remember, giant cell arthritis is not just causing arthritic AION. It can also produce cranial nerve palsies. And many of these present with intermittent diplopias. Okay, so intermittent diplopias, I mean, normally you would think of something mild or harmless as decompensating phoria. Little more serious, maybe myasthenia gravis, because it has generalized issues as well. But this is important to remember: temporal arthritis, intracranial aneurysms, impending basilar occlusion, hemorrhagic brain, all serious issues here. So these can all produce intermittent diplopia. So all intermittent diplopia or intermittent ptosis is not myasthenia gravis. Okay. Point number 4. Please remember, if you have cranial nerve palsy 3, 4, and 6 plus visual loss, okay, that is serious. So temporal arteritis or orbital apex syndromes or pituitary apoplexy, you saw some wonderful pictures just now by a previous speaker. So keep that in mind. Here comes the second case. This is a 67-year-old female, double vision since 1 week, started with a lid droop in the left eye. It was intermittent, slightly worse in the afternoon, but now it is a lot more worse. She's a diabetic and hypertensive, and you can see this moderate ptosis of the right eye. There you go. Okay, actually it should be the right eye is normal, sorry. Yeah, it's moderate ptosis the left eye, my mistake. Left eye nerves, ocular motility was nil, but as far as the third nerve is concerned, fourth and sixth abduction and intorsion were present. Pupil, as you can see, no anisocoria, everything else was fine. So once again, would you do an MRI in this patient is the question. Okay. What if the ptosis were now complete? If you say there's a complete ptosis and a complete external ophthalmoplegia and a normal pupil, would you still consider doing an MRI? Okay. So this patient was again advised a review after 1 month, saying the ptosis, everything was fine. Let's take a look at things. 3 days later, she presents with a mild headache, and now you can see the ptosis is total, and now there's a little bit of anisocoria which has developed. Okay, which brings us to a question: how long would it take for an ischemic third nerve palsy to improve? Normally, it should start getting better in about 8 weeks. Okay, or at least in a month, you should start seeing some changes of improvement. Okay, and thirdly, when do you call a patient for such patients for a review? You don't tell them just because it gets better after 3 months, come after 3 months. That's not the right way to do. As you can see, this lady had this inside. This is an aneurysm. So pupil, remember, bad things get worse. Okay, so ensure follow up at the right time. As far as pupil sparing aneurysmal third nerve palsies are concerned, they can get involved over 14 days and sometimes even as close as 48 hours. So even if you say that someone has got a diabetic third nerve palsy, if you think that is the case, don't tell them to come after 10 days or 2 weeks later. Just see them over the next couple of days in case the pupil changes. Okay, that's important, and at least for the next 14 days. So don't send them off and tell them to come much later. Okay, so pupil sparing third nerve, aneurysmal third nerve palsies can turn pupil involved over 14 days. They will not can, they will. Okay, so the question of course is, do you do neuroimaging for all cases of third nerve palsies? Do you just observe or do you do MRI with MRI brain? There are situations, there are many cases where there's a significant number of pupil involvement in diabetic nerve palsies. We commonly think of diabetic nerve palsy as pupil sparing, but you can see mild anisocoria, not much more than 1 millimeter or so, but you do get pupil involvement. Conversely, you have aneurysmal third nerve palsies, as you saw, which can present initially with pupil sparing. So the current understanding is, as far as third nerve palsies are concerned, irrespective of what it is, any third nerve palsy, irrespective of age, we go ahead and do the scan. Okay? Here is one more case, case 3. This is a 48-year-old lady. Some of you may have seen this video earlier. 3-month history of right eye ptosis, diplopia initially, but not now. So here you can see the ptosis. There is no adduction. Abduction seems almost full. In depression is missing and elevation is missing. So in this case, we want to see is the superior oblique working, is the fourth nerve. So you ask the patient to abduct the eye and from up to down take a look. If anything is moving here, hardly anything is happening there. The important thing is when she is abducting, you can see a slight amount of scleral show there. Okay? So there's a slight abduction limitation, but see more importantly the speed at which the abduction happens here. We'll show it in slow motion. You can clearly see the slow saccade. You see how quickly this eye jumps. The left eye jumps on adduction, but the right eye goes a little slower. There you go. This is already done and this is still moving. So a slow saccade is very, very important. So this patient actually had a large aneurysm in the internal carotid near the cavernous sinus. So slow saccades equals subtle nerve palsy. It's neurogenic. If you have limitation of movement, but the saccadic speed is perfectly fine, think of a restrictive cause, like for example, thyroid muscles are thick. They may not move the eye fully, but they will move it fast enough. And sometimes you can have lightning fast saccades which start to become slow as you keep on testing them. That's myasthenia and CPEO and things like that. Okay. Why I put this slide up is these are different gradings of aneurysms and the survival rate, and the more serious as it goes down with the Glasgow Coma scale. And I'd like to highlight this particular point. Grade 1 and 2, where the survival rate is 60 to 70%, this is in your hands. If you pick up this cranial nerve palsy before anything else has developed, you're giving the patient a very good chance of survival, as opposed to further down on the list. Okay? So it makes a huge difference as far as life is concerned. Final case here. This lady, day 1, 5 p.m., I put the timings here, 39-year-old fever, diabetic ketoacidosis, diplopia with orbital pain, 9 p.m. diagnosis of orbital cellulitis. She was started on antibiotics, and ENT was called to check if it's mucor, and that's what you see right there. You can see the paranasal sinuses are all filled up. Okay. Day 2, 2 o'clock in the morning, she was intubated, sent to the ICU. The ENT picked up this necrotic tissue. She started on amphotericin B, sent for frozen section after debridement. The frozen section came back with mucormycosis. That's at 1 p.m. the next day. Okay, that's what you see there. And at 5 p.m. the patient expired. Okay, this can go really, really fast. Okay, so please be aware. This is where you need to cut red tape. You need to really jump. Okay, so multiple cranial nerve palsies. Please remember combinations 3 plus 4 plus 6, or anything with the second nerve involvement. Look at the fundus, do the fields. Anything with the fifth nerve involvement, check corneal sensation, facial sensation. Remember orbit, okay? Cranial nerve palsies with the proptosis, that's important, or with paranasal sinus disease, okay? Now, this is the problem nowadays. To scan or not to scan, isolated oculomotor, any 3 or isolated 4 or isolated 6 in an older individual. Do you scan or do you not scan? So traditionally we say in an older person with vasculopathies, isolated, we can observe spontaneous resolution usually happens. The fear factor here, of course, is if we don't scan, are we missing something potentially treatable or potentially life-threatening? On the other side of it, Madhura Tamhankar came with this study. It's a multicentric prospective study, 2013, where they did MRI and MRA for all 109 patients or so that they had, irrespective of age, who seemed to have isolated nerve palsy. Okay, 16. This is the important take-home. 16.5% had structural lesions on the MRI, which included tumor, cancer-related, aneurysm, strokes, apoplexy, giant cell arteritis. Interestingly, if you excluded third nerve, which we normally would have done an MRI anyway, and you exclude giant cell arteritis, which you can pick up, and you looked at only the fourth and sixth nerve with no other risk factors, you still had about 4.6%. Okay? So the question here arises, is this significant? Do we do anything? Here comes the cost factor. You'll pick up something possibly, maybe remote, but you have added time and risk of IV contrast. So this is where the debate lies now. I think generally a middle path is fine. Elderly person, if it's third nerve, has a higher risk. Okay? Right at the bottom, at the other end, is a fourth nerve palsy, which is usually due to trauma or ischemia or something, hardly ever due to anything serious. And somewhere in between will come the sixth nerve. So that's where you can take a call. So I think it's important to have a good review of history. I think you know everything, but I'd just like to highlight this. Dizziness is something we don't often ask for. is a sign of vertebral dissection. So if you see a third nerve or a cranial nerve palsy with dizziness, be careful there. Okay, vasculopathic risk factors, you all know that, and past history is important that way. I'd like to end with this thing. These are principles to live by. I think it's a quick recognition of serious situations. This is where you need to cut administrative red tape and hospital staff delay, and believe me, it really happens that way. Prioritize imaging and blood investigations. If you think GCA, just do the ESR. That's all you need to do. You don't need anything else. Okay. Sometimes MRIs may take time, cost issues. Get a CT at least done. It may show you something to help. Okay. And very, very important, do interact with your colleagues in other specialties, particularly our radiologists here. We don't give them half the time information, sufficient information, along with the neurologists, neurosurgery, and of course the ENT. With this, you'll probably save many, many more lives. Thank you.
Naveen, I hope you are writing a textbook on neuro ophthalmology.
No.
Please do. Please do.
Thank you. Thank you. I think I have to thank Didi for this. He said, we want something more advanced for you, all you people. So this is what I came up with. Well, I have a new talk now. Thank you, Didi.
Okay, so Naveen has probably blanked out our neurons, and now he's going to go to a session of no idea.
Okay, now I'd like you to all pick up, I don't know, does soup come here or you have to go there? You have to go. Ask them to come here. Each table, you all have a piece of paper. Get ready. Test is coming. Nothing serious, okay? Can you blank that out 1 minute while I change the slide? Otherwise, we lose the element of surprise here. Thank you. That's very dramatic. It's like a curtain closing. Okay, for purposes for the next 15 minutes, this is team 1, okay? Team 2, team 3 at the back, 4, Swati is there, 5. Where's AKB? He's disappeared. 6, just at the right moment, yeah. When you don't need him. Okay, this is 6, okay? All of you just put your team number on the top, keep the sheet of paper ready. Your team 1. So this is purely for fun. This is not a test of IQ, ophthalmic or otherwise, okay? Just a little quiz, because this is what I also do, okay? Curtain be removed, yes? Thank you, thank you. So, this is what is called no idea. Is not, you don't have no idea about anything. I'm sure you all have a lot of ideas, especially with my first 10 questions, okay? This is KYC, know your Calcutta, 10 points each. At the end of each, everyone's looking very embarrassed now. Okay, at the end of 10, you can exchange papers, 1 and 6 across the team, okay? And then we'll correct it. I don't trust you to correct your papers yourselves, okay? Right, okay, here comes the first question. You write down the answer. Once the 10 is over, we'll exchange papers and go look at the answers, okay? Okay, what 3-word evocative description of Kolkata came from the title of this 1985 novel, which was later filmed in 1992. The location of the novel, however, was based on an area of Pilkhana and Howrah and not Calcutta technically. Don't shout out the answer loudly in case you want to give the answers to the others. Or you can shout out wrong answers also, that's fine. Okay, done? Right, next one. Team 7. Okay, next one. It's a quote. It's strange, she said. I've changed buses here hundreds of times. I can't even begin to count how often I walked past this wall. But I never noticed that inscription up there. These words are said by Urmila, one of the major characters of Amitabh Ghosh's novel, The Calcutta Chromosome. This is the wall of which institution and whose poem would you find on a plaque here? Wall of which institution and whose poem would you find on a plaque here? There are a lot of clues in that poem. It says, cunning seeds of million murdering death. Okay? Everyone's answered everything so far? Good. Good, good, good. Right. All three players who made up the legendary trio of Kolkata football only scored once for India, which was at the Asiad at Jakarta in 1962 versus Thailand, en route to India winning gold. Who were these three greats? So if you get two right, I'll give you half points, and you get the full points for all three names. There's a reason I put this up, because of recent events. So, okay, right. A lot of answers I can hear directly from here. Good. Okay, where in Kolkata would one come across, sorry for the spelling mistake, Japanese flower garden, Harinalaya, and replicas of wonders of the world? Okay, next one. What is his name? If you have wrong spelling, it's okay, but right spelling would be nice. Okay, next one. The Registrar of Chennai GI, which is the Geographical Indicator Office, issued 2 GI tags in 2017 and 2019 respectively for which product of the same name but differing physical qualities from 2 different states. This is the only time I've seen everyone smiling after 2 hours. Very sweet. Okay, next one. Okay, you have to name this 2005 film by Pradeep Sarkar. I need the sound. And this scene is a tribute to which 1964 masterpiece? Okay. Just 1 minute. Sound up? Okay, so take a look. What follows now? Okay. So 2 parts. I want the 2005 film, which you just saw, and the scene that you saw in this film is a tribute to a 1964 masterpiece. Which is that one? Both the films. If you get one, you'll get half points, 5 points. Okay? Okay. All set? Next one? Okay, while Nawab Wajid Ali Shah left Lucknow, his Lucknow never left him. Which area on the fringes of Kolkata where he settled is remarkable for its Nawabi architecture? While its name means mud tower, it is often described in heritage tours as the Chota Lucknow of Kolkata. Name of this area. Name of this area where this is all located. Wajid Ali Shah settled down here. Okay? And continuing on this theme is the next question, I think, question 9. So these are 2 stories about what unusual ingredient unique to the Kolkata variation of a popular Indian dish. Story 1. The exiled Wajid Ali Shah was a food lover but did not have enough money to buy sufficient meat for this dish. Story 2. There was no shortage of funds, but this vegetable was included as it was considered exotic. What are we talking about? So just a few words will be fine. Okay. Everyone knows this. Good. Okay. Here comes the next one. Food everyone knows immediately, right? 1938. For the annual session of the Indian National Congress in Haripura in Gujarat, Mahatma Gandhi called upon which artist for the decor? The posters this artist created for these are known as the Haripura posters. The same artist also created artwork in 1950 that embellished the pages of which important legal document. Okay, two parts. Here are the pictures. These are some examples of the Haripura posters. Okay, and the next one is a close-up of one of his drawings done for this document. What is this document? And who is the artist? No, you have to write. You don't tell me anything. Okay? All done. So why don't you exchange papers quickly? Team 7, correct yourselves. I'm the referee. Okay, quickly. Then you can all... I think everyone's woken up after this. Okay, all done? Right. Shall we do? So just put a tick and put 0.5 or something like that for the half points. Okay. And then remember each question has 10 points. Okay. Okay, this one. City of Joy. Yes. City of Joy. Okay. This one. Very good. So this is the poem by Ronald Ross, and this is just on the northern wall of the PG hospital. That's Ross's laboratory there, and Ross wrote that poem about his discovery of malaria. Okay. So 5 points for PG hospital, 5 points for Ronald Ross. Is it under lock and key? Incidentally, actually, if it was interesting, you look at it, he is actually the city's first Nobel laureate. There's some additional PhD level stuff coming from this side. So, okay. See, all this I don't know. Yeah. Okay. What about this? And absolutely right. I'm sure everyone got that. Okay. Tribute to Balaram, who passed away recently. This one, very, very easy. Eco Park. This one? No. It's named after it sounds like a martial artist, but it's named after a river here. Yeah. This is the mascot of Kolkata Knight Riders. His name is Hugh Lee, like Brett Lee, okay? Or Bruce Lee, okay? Okay. All right. Next one. Finally points to me. Okay. Yes, I think you all got this. These are the two rasgullas. Okay. Okay. This one. Parinita and absolutely right. This is the Charulata Singh. Okay, right. This one? Metia bruise. Metia bruise from mati, meaning mud. Okay. This, I believe, everyone got and even wrote down the recipe for it or something somewhere. Yeah. Right? Okay. The curious case. Actually, the first story is a bit of a gup told by the British that he had no money and all that stuff. Okay. This one? Nandalal Bose. Well done. Well done. This is Nandalal Bose, and he did the illustrations for the original Constitution of India. Okay. AB, will you note down, please, quickly on one paper? Team 1, how much can you return your papers and add up the scores? Now we come to the embarrassing bits. Okay, team 1, how much did you get? 8. That is 80 points. 80 points. Team 2? Team 2, you got 90. How much did you get? 600, so 65. Okay. Team 3?
That is team 6 is 65.
No, team 2 is 65. Okay. Please get back your papers. Okay, yeah. Team 3, quickly.
35.
35. Failed. Team Kolkata, send you to Chennai. Team 4. 70. Well done. Team 5. Yes. 50. Well done. And team 6? 80. Well done. I think team 3 has got too much neuro ophthalmology stuck in their heads. They got only 35 out of this. Okay.
There's a tie.
Doesn't matter. One more round and then we'll adjourn. This is only trivia. Ready? Quick answering now. What are these icons? Write it down. This is general, okay? Very, very popular over the past 2 years. Next question. By what older name is this state referred to in India's national anthem? You can see the outline of that state and you can see something very suggestive there. Okay, don't. By what older name is the state referred to in India's national anthem? Run through the names in your head. Just throw this man out. He's hungry, yeah. Hypoglycemic blabbering is happening. Okay. Which Microsoft program, one word, was named because it was considered superior to the existing Lotus 123 program? Take a good look at the picture. See what that picture shows, you'll have a clue.
Oh, yeah. Done.
Don't shout out anything, please. Just get some tape or something. Okay, question 4. Artist and subject. 2 parts, artist and subject. Next one. What is the name of this bowl-shaped haircut? Because it looks like a certain type of plant life. With which number would you associate this film poster? Number. Next one. Burrs are seeds with hooks that can attach to your clothes to help the seed find a new home, which you will see in the top 2 pictures. Which invention, seen magnified in the bottom visual, was inspired by burrs and revolutionized the fastener industry in 1959? It got its name from the French words for loop and hook. So the first is what you see in nature. The second is an example of something you call biomimicry, where we copy something from nature artificially and try and figure out how it works. On completion, what should be the final color of this face of the Rubik's Cube? The face that you see here. I mean, you have 6 colors to choose from, so pick. Next one. Outside whose presidential palace, or you can just tell me in which country, was this song shot in 2020?
పొలం గట్టు దుమ్ములోన పోట్ల గిత్త దూకినట్టు పొలేరమ్మ జాతరలో పోతరాజు ఊగినట్టు కిర్రు సెప్పులేసుకొని కర్ర సాము చేసినట్టు మర్రి సొట్టు నీడలోన కుర్ర గుంపునట్టు ఎర్ర జొన్న రొట్టెలోన మిరప దొక్కు కలిపినట్టు నా పాట చూడు నా పాట చూడు నా పాట చూడు నాటు 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 తీర నాటు 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 ఊర నాటు
Okay, next one. Last question. What is the two-word name? And the two words have 6 letters each. This is a devotional service with a difference by Sikhs in Delhi during the pandemic that literally allowed patients to breathe. Okay? Think of something that you'd associate of service with the Sikhs and you add another word in front of it. Both are 6 letters. The visual will help you. Just look at it. Okay, time to exchange papers. No Googling at the back. Team 1 is revising their paper, answering, underlining with color pencil, important points. There's some argument there, so full of action. Okay, all ready? Okay, the first one.
Google Duo and Google.
What is the first? What is A?
Duo.
No. Zoom. And B? Google Play. Google Meet, sorry, not Google Play. Google Meet. Okay. Zoom and Google Meet. So 5 points for each. This one? Utkal. Yeah, this is Odisha. So this is Utkal.
Windows.
Not Windows. It is superior.
Excel.
Excel. It was considered as short for excellent, and you can see all those graphs there. So that would have given you the clue. That was the clue. It's Excel. That's how Excel got its name. Okay. Mother Teresa and M.F. Hussain. Well done. M.F. Hussain, Mother Teresa. This one? Mushroom. Yes. This one? 83. And if you want to be kind, you can say 1983 also. That's okay. Yes? Velcro. Yes. This is Velcro. This is how Velcro came. Okay. And those are the 2 French words which are joined together to make the word Velcro. Yellow. The centerpiece. The centerpiece never moves. So that's how you make out which side goes where.
Ukraine.
Well done. This is President Zelensky's palace in Ukraine. Okay. Unfortunately, we don't see him dancing in this clip. Okay. And last one. Perfect answer. Round of applause. Oxygen Langar. Okay. Oxygen Langar. And that brings us to an end to this quiz. Just exchange papers and we'll find out who wins this quiz for no remuneration at all except maybe a round of applause. Okay. AB, ready?
Yep.
Team 1.
Team 1.
DD is counter checking all your things whether it's right.
Yes. 60.
Yes.
When a quiz master like him stands here, there's one tip for you, sir. So once you are coming to Calcutta, and all your quiz should not have three things. One regarding the food, another one is football, and 3 is film. So if you ask 3F,
Yeah.
they will definitely surely answer the question.
That's the reason it's there. Everyone likes it. Otherwise, I can put all sorts of other questions and make you answer nothing at all.
70.
Yeah. Who doesn't want not to answer? Then I can ask you 10 questions on diplopia. Right. Yeah. Team 1. 70. Okay. Team 2? 75. Team 3? 55. Team 4? 55. Team 5? You just was 0. No points for that.
Which one?
Team 5, minus 20. Team 6? 85. 85.
Wow, how much was team 4?
Team 4 also got 55.
Okay.
So, Amitabh, use the mic and announce.
Yes. The third runner-up is Team 2, 140.
Well done.
And that's the second runner-up, sorry. The first runner-up is Team 1, 150.
Well done.
And the winner is Team 6, 165.
Team 6 will now treat everyone to a round of drinks. Thank you all. Hope you enjoyed yourself.
Thank you so much, sir. Just 1 minute, just 1 minute, just one. We will just before the vote of thanks, I'll ask my president to give his words, just two words.
Two words is thank you. So nice. Thank you, Dr. Naveen, for specially coming over here, and thank you all of you to be present into this meeting. Thank you, Didi.
Thanks to OSWG. Vote of thanks quickly.
So I think you all can start, but this isn't routine customary to do this. First of all, thanks to all the audience. In short notice, this is you all have come in a working day, partially working day rather. So thanks to all, and special thanks to Dr. Naveen Jaikumar, because for sharing his knowledge, his humor, wittiness, everything, which actually we do love. Sir, we do love to see you again here at any point of time, and would like to thank Sipla for organizing the show today, and nonetheless Giri and Shogoto and all the audiovisual team. Thank you. Thanks a lot.